Hello everybody, today we are going to talk about community-acquired lower respiratory tract infections. So what is a lower respiratory tract infection? It's an infection that touches trachea, airways and lung. Different structures can be touched. If we have the bronchi which is involved, we are talking about bronchitis, the bronchioles, bronchiolitis, the alveoli pneumonia, the bronchi and alveoli bronchopneumonia, and the interstitial tissue, we are talking about interstitial pneumonia. We have to differentiate it from the upper respiratory tract infection, which are infections involving the nose, sinuses, pharynx, and larynx. And this is commonly rhinitis, pharyngitis, laryngitis, sinusitis, otitis media, and the common cold. These symptoms are mostly dry cough, sore throat, runny nose, nasal congestion, headache, lower grade fever, facial pressure, and sneezing. And because mostly these infections are due to viruses, the treatment is symptomatic and we do not give antibiotics except for sinusitis. What is a community-acquired infection? It's an infection that is acquired outside of a healthcare establishment, which is different from what we call hospital-acquired pneumonia or most commonly nosocomial pneumonia, which is an infection that occurs at least 48 hours after an admission in a healthcare structure. It cannot be present at the admission, and those infections are mostly endogenous, so from the source of contamination is the patient himself, then exogenous, and the patient is infected by his own germs during certain cares like surgical procedures, urinary catheterizations, and artificial respiration. Caregivers can also play a role as a vector of transmission. So in pneumology, infections are also linked to endoscopy, puncture of a pleural effusion, for example, a pleural biopsy, a thoracic drainage, or a non-invasive ventilation. And the most common germs are Escherichia coli, which lives naturally in the intestines of everyone. Secondly, Staphylococcus aureus, which is present in the mucous membrane of the nose, throat, and perineum of approximately 15 to 30% of individuals. Pseudomonas aeruginosa, which develops in soils and humid environments. So, as we have said, the most common pathogens are Escherichia coli, Enterococcus, and sometimes Candidas, but rarely, but the most common is Staphylococcus aureus. The causes are some devices like urinary catheterism or surgical procedures or mechanical ventilation, and to prevent that we have to have a frequent hand hygiene. We have to put gloves to remove these devices responsible of these infections, a routine disinfection, and to give antibiotics appropriately. What about opportunist infection? It's an infection that is usually benign for a immunocompetent person, but it can cause disease for a person who have problems with his immunity, like patients who are living with HIV. And the most common germ is what we call Pneumocystis jirovecii. So these community-acquired lower respiratory tract infection are a frequent reason for consultation, with an annual incidence of lower respiratory tract infection of 51 to 84 per mil, and annual incidence of pneumonia of 1.6 to 19 per mil, with a significant morbidity, 6% of general medicine consultations and 4% of all the hospitalizations. It is the fourth cause of death in the world, but thanks to God, it has decreased considerably from 10 million in 2000 to 2.6 million in 2019. So what are the types or the classification of these infections? According to the anatomy, we have what we call acute bronchitis, which is the inflammation of the bronchi. It affects over 40 adults per mil per year, and the viruses are the most commonly causes of these infections. The patient presents himself with lower grade fever, heartburn, cough preceded by upper respiratory tract infection. At the physical exam, we have a normal auscultation or sometimes some bronchial rales, and we do not give antibiotics because, as we have said, viruses are the most common cause of these inflammations. Secondly, we have the acute pneumonia, which is the infection of the alveoli or the interstitial tissue of the lungs, and most commonly they are transmitted via the aspiration of some pathogens or the aspiration of the stomach content. Clinically, it manifests with a high fever and chills, some productive cough with purulent sputum, tachypnea and dyspnea, and we could have some chest pain due to the inflammation of the pleura, viscera, or even a pleural effusion. At the physical exam, we have what we call the consolidation syndrome, with an increase of tactile fremitus, a dullness on percussion, a decrease of breath sounds, and some crackles or bronchial breath sound on the auscultation. The chest X-ray confirms the diagnosis, and the treatment is antibiotics because this time the pathogens responsible for pneumonia are bacteria. And of course, we could give some supportive measures like oxygen administration or antipyretics if we have fever. So as we have said, those are normal alveoli, and in pneumonia we have the presence of pew or some cells at the alveoli. Secondly, we are going to talk about infection depending on the age or on the term. So, for example, for pneumonia in elderly individuals, they are a frequent cause of mortality, and it is distinguished from pneumonia in young people by the clinic first. In the elderly ages persons, we have no fever, and we have mostly the compensation of chronic disease than really respiratory symptoms. And sometimes we have neurological symptoms. On the chest X-ray, the topography of lesions are frequently the lower lobes because these infections are mostly due to the inhalation. So the infection will go to the lower lobes, and we have a slow regression of the lesions. What about pneumonia among children? This time we have some clinical presentations as pseudo-surgical forms with vomiting and abdominal pain, pseudo-meningeal forms. The physical examination is very important. It could orientate to this respiratory infection, and we do have to do a systematic x-ray for every children who have a fever that we could not explain by another cause. And others, we have pneumonia, as we have already said, revealed by the compensation of another pathology. What about classification depending on the germs or the pathogen? Firstly, we are going to talk about the most prevalent one, which is Streptococcus pneumonia, or what we call pneumococcus. It is due to the colonization of the four oropharynx, so we have no aerial contamination and no epidemic nature. Typically, the subject is aged 40 or over and had associated comorbidities. And clinically, we do have nasolabial herpes, which is orientated us to that germ. Secondly, we have what we call Mycoplasma pneumonia. It's second etiology of community-acquired pneumonia. It develops in small epidemics with an incubation of 1 to 3 weeks. The general signs are instilled first with headaches, high fever, chills, myalgia, often pharyngitis, and cervical adenopathies. Then we have the respiratory signs 2 to 3 days later after the general signs. Third, we have Haemophilus influenzae, which is a gram-negative bacillus and often secreting beta-lactamase, so we have to pay attention while giving antibiotics, because we have to give antibiotics against those beta-lactamase. We have a frequency of contributing factors that we found in these patients, like alcoholism, cirrhosis, smoking stage 2, COPD, or some bronchial lesions. Fourth, we have what we call Legionella pneumophilia, which is an intracellular gram-negative bacillus present in the water environments, and it is mostly responsible for some extra respiratory signs like digestive disorders, headaches, and confusional syndrome, which are associated, of course, with some respiratory signs. And we could have other germs like Enterobacteria, E. coli, Klebsiella, Staphylococcus, some anaerobies, and some Piocyanics. We do not have to forget about viral infection, which are epidemic. They are seasonal, like influenza A and B, and they are responsible for some general signs like malaise, asthenia, myalgia, fever. And on the chest X-ray, we do find some bilateral non-systemized reticulonodular opacities, which can orientate us to those infections. So, what we have to remember, we have no correlation between the clinical presentation, the radiological one, and the germs. And these pathogens are not found in more than 15% of cases, even if we do a lot of bacteriological examination, we do find these germs only less than 50% of the cases. The Streptococcus pneumonia, the Haemophilus influenzae, and the Mycoplasma are the most frequent agents. Atypical germs like must be taken into account if we have less than 40 years, no comorbidity, and infection of the upper respiratory tract. Gram-negative bacillus, Legionella staph aureus, in case of serious infection on a particular thyroid, and they mostly need hospitalization. What about complicated forms? You could have a complication, especially for pneumonia, with what we call parapneumonic pleuritis, which is an inflammation of the pleura viscera, and it will be responsible for some chest pain, and on the exam we could hear some friction rap. We do give analgesic to relieve the symptoms. The parapneumonic pleural effusion, which is presence of liquid and pleural space, and we could also have the pure and pleural space, what we call pleural empyema. This pneumonia can be complicated by lung abscesses or even respiratory failure if we have some infection in the both leg or on an underlying respiratory problem. We have also what we call a recurrent forms, which is infection that comes and go in some special condition. It could be a local cause, like if we have a foreign body, a tumor or bronchiectasis, or a general cause like patients who have diabetes, who have HIV, and those infections are mostly opportunists. And we have, as we have said before, forms revealing an underlying pathology like diabetes, COPD, and heart